Hello, welcome to Creating and Maintaining a Safe and Comfortable Home, Crisis Prevention and Management Training for Limited Mental Health Assisted Living Facility staff. The purpose of this training is to increase the knowledge of mental health and behavioral issues and skills of limited mental health licensed assisted living facility staff to identify, prevent, and manage crises that potentially occur in the limited mental health assisted living facility home. The intent of the training is to reduce the incidence of crises in the limited mental health assisted living facility by reducing stigma and misunderstanding related to mental illness and behavioral issues that may trigger agitation, to promote positive relationships between staff and residents, to increase basic skills to assist residents that may be developing or in crisis, to become more calm and safe, to provide information on how to obtain professional help and resources in a crisis if necessary, and to increase staff members' personal sense of value and efficacy. Hi, I'm Margo Fleisher, Program Manager and Trainer with Central Florida Behavioral Health Network. This training is brought to you by the Florida Statewide Limited Mental Health Assisted Living Facility and Agency for Healthcare Administration Training Work Group. This training is based on information from Assisted Living Facility Training for Limited Mental Health Licensure, the 8-hour certification program developed by the Department of Children and Families and the University of South Florida, Louis de la Parte Florida Mental Health Institute, Department of Mental Health Law and Policy, with contributions from members of Central Florida Behavioral Health Network and South Florida Behavioral Health Network. The training also includes material from Mental Health First Aid USA, an 8-hour certification and evidence-based course supported by the National Council for Behavioral Health, designed to prepare community members to assist people experiencing symptoms of a mental illness or crisis until professional help arrives. Some of the topics we will cover in this training are what to expect in a limited mental health assisted living facility, suicide risk and how to help, what non-suicidal self-injury is and how to help, what to do in a medical emergency, strategies for preventing and de-escalating aggression, issues for residents with a history of trauma, and residents that are veterans and residents with traumatic brain injury. Remember that an assisted living facility is a home. Aside from your important skills and experience, the value you bring to the assisted living facility as a caregiver is immeasurable. Your interest in your clients and beliefs do much to create the atmosphere where you serve. Remember first that a safe, comfortable assisted living facility is a home environment. Your assisted living facility is where people live, and we wish to treat the program as a home, respecting individual space and providing for dignity. Many residents in a limited mental health assisted living facility regard you as a family member, and no doubt you know them in many cases as well or better than their biological family members. If you work full-time there, you spend more time with them than you do with your own family. Relationships are a key element to our well-being as well as for the residents. You bring not only important knowledge and skills to the assisted living facility, but your caring and sensitivity may be just as important in helping residents live successfully in the community. People living with mental illness say that a lack of acceptance because of stigma is the biggest problem they face. Stigma discourages people from seeking the help and care they need. You are one of the residents' most important allies and advocates against stigma. So let's hear a story about Jeremy to illustrate. While waiting in the emergency room to get stitches for an accidental cut on your hand, you meet Jeremy, who is in the bed next to yours. Jeremy's clothes are dirty and his hair and beard are long. He's being treated for pneumonia. Most of the ER staff seem aloof to him, and he is quiet and passive with them. The staff members talk loudly to him and use words as if he were a small child. You hear the staff members chuckle to each other in the hall when they leave his bedside. You learn that Jeremy is only in his early 40s, though he seems much older. Jeremy tells you that when he is released from the hospital, he hopes to get approved for disability. He said that he has a master's degree in engineering, but lost his job when he became so depressed he could not get out of bed for days at a time, and he stopped going to work or calling. After he lost his home, he began drinking to help him sleep when he could not get a bed at the shelter. What feelings do you have after listening to Jeremy's story? What was the reaction of the person's friends, family, or coworkers to his behavior, hospitalization, or treatment? How do you feel about Jeremy? How do you feel about the nurses? How might the responses be different if the illness he had was a different one, such as a heart attack or a broken leg? If you're viewing the training with a group, you can stop it for a few minutes and talk about your reaction to this story. What is discrimination? Discrimination is the unfair way people with mental illness are treated. So discrimination not only causes shame and prevents people from seeking help as stigma does, it can cause them to be denied some of their most basic needs. Remember, though, that not all mental illness leads to disability, and not all disability is permanent. The people that you serve in the assisted living facility live there because they experience a disability due to their mental illness. Words are powerful. Words can be used to communicate stigma or acceptance, to discriminate, or to be inclusive. Language shapes our perception of the world, and your words tell the resident how safe and valued they are in the assisted living facility home. Think about how you felt if anyone ever gave you a nickname you didn't like. But hearing our name spoken by others is one of the most beautiful sounds to us. Remember that people are not their diagnoses. There's more to us than an illness, so don't refer to someone as a schizophrenic. If I have anemia, I don't refer to myself as an anemic. Let's do an exercise and think of words we may have heard out in the world or in the media to describe people living with mental illness. Let's stop the training for a few minutes and write some of those words down. So let's write down some of those words you may have heard out in the community or in the media that describe people living with mental illness. Think of times you may have been set off by words that someone used about you or someone you care about. Think of times you saw a resident go off in response to words. Think about important parts of your identity as a worker, family member, part of a culture, your beliefs, and how it feels if someone would seem to insult those important things, take them away, or give you an identity that doesn't fit. We need to be mindful of stigmatizing language because it can enter our everyday usage in unintended ways through things like movies, music, TV, and social media. Words can seem acceptable when they are not. So what are some appropriate affirming words to use to describe someone with a mental illness? Things like you see here. The person's name, person living with a mental illness, a person in recovery, a person with lived experience, such as substance misuse, mental illness, trauma, an individual living with schizophrenia, a person with bipolar disorder, or a person experiencing symptoms of something else. Let's look at some myths about mental illness that contribute to stigma, discrimination, and the facts. A common myth is that mental illness is uncommon, so people with mental illness are different, when in fact, the prevalence of a mental illness in any given year is 1 in 5, or nearly 1 in 5, and the lifetime prevalence of having any type of mental illness is nearly 50%. So having a mental illness at some time in our lives is kind of normal. It's very likely that we live with or are close to people that live with mental illness outside of our work. Some mental illnesses are rather common, such as anxiety and depression, and some are less common, like bipolar disorder and schizophrenia. Anxiety disorders are the most common mental illnesses experienced among Americans, with an occurrence in nearly 1 in 5 people in any given year. Another common set of myths are that people with mental illness bring it on themselves, or that they caused it by damaging their brains with drugs, when the facts are that no one would want to live with a mental illness, of course. Mental illness actually occurs due to the interaction of a combination of biological and environmental factors that are beyond a person's control. It's important to note that the national comorbidity surveys indicate that more than half of people with substance use problems have mental illness, and 90% of those people, which is almost everyone, experience the symptoms of their mental illness before initiating drug or alcohol use. Also, for instance, the median age of onset of an anxiety disorder is 11, so this is a statistic that shows that a lot of people experience the symptom of their mental illness before they begin experimentation or self-medication with drugs if they have a co-occurring disorder. Some more myths and facts. A prevailing myth is that people with mental illness just don't want to take medication and do what it takes to get better, and that they're lazy. The facts are that mental illness is more treatable, and there are better outcomes with mental illness than with a lot of other chronic illnesses like heart disease or cancer. On average, people with mental illness are more adherent to their prescribed and recommended treatment than people with infections or other chronic medical conditions such as diabetes. Most people with mental illness don't become disabled and continue to work and lead productive, fulfilling lives. So that breaks up the myth that people with mental illness just don't want to work or are lazy. Mental illness is a primary cause of homelessness for Americans, and yet 40% of people that are experiencing homelessness due to mental illness try to engage in some kind of employment. This may be the most important myth related to mental illness, the myth that people with mental illness are dangerous or violent. The fact is that people with mental illness are more likely to become victims of violence than to perpetrate it. Only about 4% of community violence can be attributed to mental illness. In the unusual events that people with mental illness do violent acts, it's more likely that the violence is done against themselves or someone they know. So random acts against strangers and gun violence by people driven specifically by mental illness are exceptionally rare. Anger, access to weapons, and substance use are better predictors of violence than mental illness. So as the poster suggests, the misconception of the dangerous person with mental illness comes from the media and our general culture. There are other cultures, for example, in which persons with psychosis or other symptoms are revered. So if we don't expect escalation in violence, we're less likely to have it. It's reassuring to know that it is relatively safe to work with people living with mental illness. All of that about stigma and myths being said, there may be times a crisis can start to develop or emerge with people living in a limited mental health assisted living facility. The mental illnesses are relatively common, and most people that experience mental illness are not permanently disabled. People living in the limited mental health assisted living facility are there because they have some long-term disability due to mental illness. So these are some situations that we will address: suicidal thoughts, non-suicidal self-injury, medical emergencies, and verbal and physical aggression. So let's address some important points about suicidal thoughts and what some risk factors are. A number of mental disorders, including depression, increase the risk of suicide, not just depression. So what other mental disorders? Those could include things such as bipolar disorder, anxiety disorders, and disorders that involve psychosis. An important fact, people without a diagnosis of a mental disorder sometimes attempt suicide also. And why would that be? You don't need to have a mental disorder to go into a crisis or become suicidal. People have suicidal thoughts and act on them sometimes when they feel helpless, overwhelmed, or trapped. Substance use is also associated with suicide attempts and deaths. The association is that it may be that they don't wish to die rather than they wish to escape from intolerable pain, which substance abuse is often a part of that. Suicide risk is higher in adolescents and young adults and in the elderly. There's some reasons for that. Suicide risk may be higher in young people because young people have incomplete cognitive development, have less life experience, and acquire fewer coping skills. They might be more impulsive and have poor judgment. They may be more susceptible to influence from other people and have more intense moods and emotions. Meanwhile, elderly people may be more at risk for a few reasons, such as increased social isolation, loss of resources when their employment ends due to voluntary or involuntary retirement, medical problems and physical pain, relationship losses and grief, and a diminished value for aged people in our culture. It's a fact that men die by suicide more often than women, but women attempt suicide more often than men. Some reasons for that are that men tend to use more aggressive or lethal means in their suicide attempts. People with a history of suicide attempts have a higher risk of later attempts, and it's supposed that they may find it easier to attempt again because they've become more invested in suicidal thinking and they've become more comfortable with the idea of it once having attempted it before. So here are some suicide warning signs to consider. Talking about killing themselves and death, directly or indirectly. Preoccupation with music and art with a suicide or death theme. Appearing more withdrawn than usual. Appearing more agitated. Seeming to have no future plans or commitments. Giving away important possessions. Saying goodbye. Collecting means for the attempt, like pills, ropes, or weapons. And after a period of sadness or distress, suddenly they seem happy and peaceful. We're going to talk about why that might be. If we see any of these, we want to pay closer attention. It's a warning sign if someone really seemed to be struggling and suddenly they seem peaceful, because it may mean that in ending their life they found a solution to their problem. We should ask them about that. A reason for any of these is that people with suicidal thinking are not thinking as clearly as they do when they are well. So how to help someone with suicidal thoughts? We should always take any statements or gestures seriously. If we see some signs or hear statements that concern us, we want to ask the person directly about suicidal thoughts. Feeling anxious about that is normal, but we should strive to project calmness and acceptance. It's very reassuring to a person in crisis that someone is ready to help. Asking someone about their suicidal thoughts reduces the isolation that contributes, and it's often a relief to people to talk about their secret. Asking this question does not make the problem worse, but it can save a life. So we want to ask the question directly, are you thinking about killing yourself? Or are you having thoughts of suicide? It might be a good idea to stop the training for a few minutes, and if you have someone with you, to practice asking these questions. The good news is, if you ask someone about their suicidal thinking, and if they indicate that they might be thinking about suicide, you can get help for them and you can keep them safe. So there are a lot of resources to help someone with suicidal thoughts. If there's any immediate danger, if the person is agitated, if they're close to weapons or other means, if you're at all concerned about your safety or the other person's safety, just call 911. If you can, notify the supervisor of the program. If the person does not have an immediate plan for suicide or access to weapons or other dangerous things, you can activate some different types of support to get them safe, like contact the sheriff's department and ask for a crisis intervention trained officer. Contact the mobile crisis team in your community. Or if you can reach the resident's case manager, ask them for assistance. You can help the person call 1-800-273-TALK or 1-800-273-8255, the National Suicide Hotline. Some things to not do are to never agree to keep their statements or their plan a secret. Don't use guilt or religion to try to talk them out of it. We'll talk about why. And don't leave them alone. Many communities have local crisis stabilization and prevention resources. We never agree to keep suicidal plans or statements a secret, because that is a weight we should not carry on our own, and keeping their secret may enable someone to do harm to themselves that they would not or could not if their plan was brought out in the open. Keeping suicidal plans a secret can add to the stigma of mental illness. If a secret is shameful, but it is shared, then there's hope. Your religious beliefs can be very valuable to you, but when someone in crisis and not thinking clearly, primary focus on religious beliefs can create barriers. Someone in crisis or who is suicidal may think they deserve to go to hell, for instance, or that they deserve to suffer, and that their loved ones will be better off without them, or even wish for them to die. So never leave them alone, but if you can't stay with them, there are people you can call to assist. So what is non-suicidal self-injury, and why do people use it? Non-suicidal self-injury is harm intentionally inflicted as a means of coping. People that use it say that it helps to dissipate intense anger, anxiety, or sadness. They say they do it when they feel the need to be punished, or they say it's a way of expressing unspeakable feelings to others. Some say they do it to relieve feelings of numbness. It should not be treated as an emergency unless the harm becomes a medical concern and it is not a failed suicide attempt. It's an attempt at coping. Some information about medical emergencies. Medical emergencies can arise due to medication side effects. They can arise due to an intentional or an unintentional drug overdose. Or there can be delirium related to a medical condition, or due to some other process. There can be a number of other medical emergencies due to accidents, due to exposure, a number of things. But this information is to help staff recognize a medical emergency. And some changes that you can see in a person may initially be subtle and look like behavioral issues. Most of us are not qualified to determine what someone is presenting, if it's a behavioral issue, a minor medical issue, or something more serious. So if in doubt, just get your administrator or call 911. So now we come to a portion about verbal and physical aggression. Remember, aggression is really not the expectation of people living in the limited mental health assisted living facility, but we should be prepared for it. By knowing the residents and their personalities and experiences, we can be aware of their triggers and prevent some verbal and physical aggression. And by having good relationships with residents and other staff, we can often de-escalate a crisis before it really becomes a crisis. We want to try to have the attitude that if something can go well, it will. Remember that aggression and violence are not at all necessarily part of a person's mental illness, but anyone can become agitated when under stress. And the stress can be a part of the person's mental illness. Here's some information about nonverbal communication. We can do some things to prevent and de-escalate aggression in the limited mental health assisted living facility by being aware of our nonverbal communication. If you look here, here are some examples of postures and facial expressions that may look pretty typical to us, but the effect can be to provoke or exacerbate agitation in a subtle way. Most of what we communicate is nonverbal, unintentional, and can send mixed messages. Be aware that our words can lie, but our body does not. So a lot of the things that you see in this picture here are some less than ideal ways of communicating using nonverbal communication. They send some confusing or negative messages. So what are some better ways? Here are some examples. Here are some postures and facial expressions that promote a relaxed atmosphere and de-escalate crisis. So for instance, try to make eye contact with people, but without staring at them. Turn your body toward the person or angle it slightly away from them. It's better to sit next to someone than across from them, though. Try to keep your hands out of your pockets, or try to keep your arms from crossing across your chest, or hiding your hands behind you. Keep your hands at your waist level or lower, and try to keep your hands open. At an appropriate time, a smile is nice. It may seem to take more time to slow down and be mindful of our nonverbal communication and to use calm speech. But it takes longer to de-escalate a crisis, to clean up afterward, or to do the paperwork related to it. So we want to attend to our nonverbal communication. Here are some de-escalation strategies if a crisis does begin to emerge in the limited mental health assisted living facility. Try to reduce the volume of your own voice and try to keep yourself calm. If you talk more softly, the person has to focus better to listen to you. And if you get loud, the other person will get loud. Try to use positive language instead of negative language. So some examples of negative language you want to try to avoid are don't do that, or stop that, or no. Some positive language might be something like, let's try this, or take a walk with me, or let's go outside, or let's do some push-ups. Offer a person 2 or 3 options for how they can calm down. Do you want to have an iced tea with me, listen to some music, or lay down on your bed for a while? Could be some examples. If you can, give the person physical and emotional space. Let them blow off some steam as long as it's safe to do that. So it's okay if they want to pace around for a while as long as they don't get more agitated. Take the person to a quiet area away from onlookers if you can, or have the other residents move away. Moving others away or going to a quieter place alone will decrease the energy in the room and help the person calm down. Encourage the person to sit down with you. They'll sit down if you sit down. If you continue standing, they're going to continue standing. Offer them a drink or something else soothing. Offering them a drink and having them sit down with you is a natural way friends help each other. But always remember that your and the resident's safety is the first priority. So if the situation becomes unmanageable, go to a safe place and call 911. Here's some information about trauma-informed care in the limited mental health assisted living facility. Trauma-informed care guides the conversation from where it used to be asked, what's wrong with you, to what happened to you. A trauma-informed organization is a human services or healthcare system whose primary mission is altered by virtue of knowledge about trauma and the impact it has on the lives of consumers receiving services. Those are our folks. Keep in mind that trauma-informed services are not designed to treat symptoms or syndromes related to violence, abuse, or neglect. That's trauma-specific services. So we're not going to be concerned with treating trauma in the limited mental health assisted living facility, but providing a healing environment. Regarding trauma, it's surprisingly common, though typically concealed and unrecognized. Some research about that in the Adverse Childhood Experiences study with 17,000 healthcare program participants, it was found that 11% of participants experienced severe recurrent physical abuse in childhood. 22% experienced contact sexual abuse in childhood, which was an average between 28% for females and 16% for males. 22% of participants had a period in childhood with no biological parent present. This study is with a population of educated, middle-class, mostly working people. So the prevalence of trauma among our residents in the assisted living facility will be much higher. We need to know some things about what kind of trauma people living in the assisted living facility experience, so we can help avoid unintentional re-traumatization. We also want to take universal precautions as we see how nearly universal the experience of trauma is. We don't have to be therapists to have an important healing effect, though. Healing happens in a relationship. When you know the triggers, you can help prevent or de-escalate a crisis in the limited mental health assisted living facility. Triggers can set off powerful reactions to current events based on past experiences, and the triggers can be related to someone's mental illness as well as trauma. The trigger and reaction can be seemingly unrelated to the past events. When we know our residents' triggers and help them manage them, we can prevent a trigger from leading to a crisis. So you see here, for example, in a non-trauma-informed environment, the trigger plus our usual non-trauma-informed response means a greater chance of a negative outcome, a crisis, a bad experience. But if we know the trigger and provide a trauma-informed response, a sensitive, compassionate, calming response, you have a greater chance for a positive outcome. So here's an example. John's roommate thought it might be funny to play a prank on him and sneak up on him and stare him with a funny mask after lights out. The plan backfired when the roommate surprised him and John jumped up screaming and hit his roommate and chased him out of the room. John's roommate said it was just a joke, but John will not calm down. He keeps pacing back and forth with a clenched fist. So here, a harmless prank led to a crisis. John's roommate didn't expect him to react so strongly, but he was triggered by the prank to re-experience anxiety from an attack he experienced in the past. That's why his reaction seems so out of line with what just happened. So obviously, some people don't enjoy surprises like that. Here's some information about the effects of trauma for veterans and military members. Some of your program's residents may be veterans, and here's some important information about service to be aware of. The psychological effects of service can be startlingly significant and important to be aware of for residents that served in the military, whether they experienced deployment or not, or whether or not they saw action. There are more hospitalizations of veterans due to the psychological effects of service than for injuries or physical illness related to service. To think about that further, here's some information about suicide and U.S. Army members. 21% of suicides in 2009 were by soldiers with multiple deployments, but 36% had never deployed, and 43% had deployed only once. So this information is for us to understand that the risk of suicide or trauma or service-related stress doesn't have a whole lot to do with whether or not a person was deployed or whether or not they've had multiple deployments. That's from the Army Health Promotion Risk Reduction Suicide Prevention Report. Over 50% of people that committed suicide in the Army National Guard in 2010 had never deployed. So once again, it isn't deployment that is as much the issue. There are other experiences related to service that contribute to the stress that veterans and military members have. So there's much more to service than we might be aware of. Only about 7% of Americans are veterans, but 20% of suicides are by veterans and military members. Many people experience the onset of their mental illness at the time they enter the military. So that can be correlated or not correlated. It's important, as we see here, to recognize that whether or not someone was deployed overseas or was in a combat role doesn't seem to determine whether or not they will have post-traumatic stress disorder or be at risk of suicide. It's also important to recognize that though our veteran residents can be at risk of post-traumatic stress disorder and have triggers related to their service, there are aspects of their service they value highly and want to respect. Many more people that serve in the armed forces return without significant behavioral health effects. Most military members, deployed or not, don't have post-traumatic stress disorder or a substance-related disorder. Service can have many positive impacts for military personnel and their families, so they may have positive stories to tell us about that we want to hear. Here's something to show how people can have a post-traumatic reaction long after the stressful event was experienced. And the reaction can seem to be completely disconnected from any aspect of the trauma, which can confuse a lot of onlookers and family members and so on. But it can help us to identify what the triggers are. For example, my veteran husband becomes upset every time we go to see my mother, his mother-in-law. And there's really nothing wrong with his mother-in-law. She's a perfectly sweet little person, so I don't understand it. But, you know, she always tries to make him feel comfortable, and she cooks him this delicious fried chicken, and he says he likes it, but, you know, still he gets agitated. Sometimes he can be unbearable. He can be really irritable and crabby to get around. You know, I wonder if, you know, the time before that he had fried chicken, it was that 4th of July when we had gone to see the fireworks at the park, and we were having fried chicken, and then, you know, now that I remember it, when the fireworks started going off, they were so pretty, and we've been waiting all evening to see those, but he didn't seem to enjoy himself. In fact, we had to leave early because he started getting really uncomfortable. You know, I wonder if that's because the noise and the smell and just the situation could set off feelings that he had because of that time he was near an improvised explosive device, and it exploded, and a lot of people were hurt. So we see here how a traumatic experience, a highly stressful experience, becomes connected from the past into something that is seemingly innocuous in the present. Triggers can become linked and chained together. This was presented by a few different people, such as Dr. Robert Moore, a consultant at Peace for Tarpon, also demonstrated by Jose Naroski in Cognitive Behavioral Therapy for Combat-Related Post-Traumatic Stress Disorder, a manual for service members. Here's some information about traumatic brain injury from the Mental Health First Aid Curriculum Supplement for Veterans, Military Members, and their families, and referenced from the Defense and Veterans Brain Injury Center. Some of the most important things to understand is that even a mild traumatic brain injury can go undiagnosed and look like a mental health issue. If someone might have had a recent traumatic brain injury, they should be screened by a medical professional that works with traumatic brain injury. And there's a great resource in the Defense and Veterans Brain Injury Center, information and referral line that you see there, if you'd like to get more information. So healing happens in a relationship. Knowing your residents makes a difference in recognizing a developing crisis and providing support towards the best outcome. You may know the people that live in the limited mental health assisted living facility as well as or better than a family member. If there's no relationship, nothing else matters. So we just received some information about how crisis for our residents in the limited mental health assisted living facility may develop and how we can prevent it, de-escalate it, and help people return to calmness and safety. These skills and knowledge are important, but what is most important is who you are to the person and how well you know them and how much you care. Julie Alvarado says, if there's no relationship, nothing else matters. It's that compassionate attitude that you bring to the home that makes the difference in helping the residents feel safe and accepted and helps them live successfully with mental illness in the community. Thanks so much for being with us for the training today.